right, good morning. Welcome to another ultrasound lecture. This is going to be one of my favorites, cardiac ultrasound in the emergency department. And we're also going to be talking about assessment of the inferior vena cava. This is really a crucial ultrasound within the field of clinical or point of care ultrasound, and particularly within emergency medicine, because we see so many patients who can benefit from this ultrasound at the bedside. And so I really think that in addition to probably the fast ultrasound, the eFast, this is probably the most useful ultrasound that you could use or integrate into your practice. And so I would encourage you to really pay particular attention to this one. Make sure that you garner all of the concepts and take your time going through this. Hit the pause button if you need to review something or look something up or really study something more in depth. Because this one can certainly be practice changing. So without any further ado, let's begin. Why would we do cardiac ultrasound in the emergency department? How does this bring value to our patients? Well, we see a lot of patients with hypotension or low blood pressure. And so one way to think about the heart is simply as you would any other pump. It is a pump that requires fluid coming into it and pipes to send the blood out of it. And so often we think of evaluating the cardiovascular system as evaluating the pump, the pipes, and the tank. When you're evaluating the pump or the heart, you want to know how good is its squeeze. What is it able to do with the blood volume that is coming into it? And then secondarily, it's often very valuable to assess the IVC to assess that tank. How much fluid is in the tank? How much fluid is available to come into the heart to be pumped out? Now, when we actually get to talking about the IVC, you'll hear me deviate a little bit from that perspective and talk about the IVC much more as a surrogate marker for central venous pressure than the fluid or volume status in particular, but more on that to come. So again, think of the heart as you would any other pump, and the first thing you want to know when you look at the heart is how good is it squeezing? We're going to refer to that as contractility. Is the contractility of the heart normal, or is it depressed, which we would term hypokinetic, or perhaps it's increased, maybe it's hyperdynamic or hyperkinetic. And so we'll refer to that as the squeeze. We'll also use cardiac ultrasound to evaluate patients in cardiac arrest or PEA. You will use ultrasound a lot in your practice to help work up the cause of cardiac arrest or PEA. But one of the first questions you want to know, particularly in patients with PEA or asystole, is to confirm the presence or absence of any cardiac motion. And the prognostic value of ultrasound to confirm the absence of cardiac motion in patients in cardiac arrest is very valuable, because those patients' survival to discharge from the hospital is bordering on zero. Lastly, we'll use it to augment our workup of patients with chest pain or shortness of breath. And I put an asterisk by this because a lot of these diagnoses that we consider in patients with chest pain or shortness of breath, point of care ultrasound may be rather specific for, but it tends to be not always the most sensitive test for some of these conditions. Although, as you'll see listed here, the pericardial effusion and tamponade ultrasound is the gold standard for, but some other diagnoses like dissection of the aorta or pulmonary embolus, it can augment the workup of, but we can't use it really to rule those conditions out. So more on that to come, but just be aware these are the scenarios in which we would want to use point of care cardiac ultrasound. So what are we looking for with cardiac ultrasound? I like to think of this as the sac, squeeze, and strain. And I did not coin that term, sac, squeeze, and strain. I believe that was coined by a Dr. John Purcell, who trained after me at UT Southwestern. But that said, sac, squeeze, and strain is a good way to remember the three things we're going to assess with cardiac ultrasound. We're going to look at the sac or the pericardium for any fluid or blood. And of course, which one it is will have to be clinically correlated. So you'll often just hear us refer to it as pericardial fluid because Clearly, we're uncertain just based on the ultrasound what exactly the fluid is. And then we're going to look for signs of tamponade. To evaluate the squeeze, again, we're going to look for the contractility of the heart. And often what we're really focused on is the contractility of the left ventricle itself, because that's what's going to generate the cardiac output. And often we're talking about global contractility, meaning the whole heart, but sometimes you may speak of just one chamber, such as the left ventricle, or you can really even have a regional wall motion abnormality, which is a little bit of an advanced topic, but I'll show you what that means a bit later in this presentation. And then lastly, strain. What do we mean by strain? We're talking about strain of the right ventricle in the setting of an acute pulmonary embolus, wherein we're looking for evidence of acute right heart strain. So those are the three things: sac, squeeze, and strain. And if you really stick to assessing those three items within the purview of emergency medicine and point-of-care ultrasound, you will definitely stay well within the standard of care. There are many advanced topics that cardiac ultrasound can get into, but I would say that those are the three that are really normative and within the standard practice for emergency physicians. Let's talk a bit about how we're going to require an ultrasound image of the heart. The heart is conveniently placed between two lungs and a lot of ribs. And we know that the enemies of ultrasound wave penetration of tissue is air and bone. Bone is going to be highly reflective of the sound waves, and air is going to scatter the sound waves. And so conveniently the heart is placed between those structures. So we're going to figure out a way to navigate that. And the way we're going to navigate those issues to find a good image of the heart is by using a cardiac probe. And the cardiac ultrasound probe is really the probe that you're going to use for all of your cardiac ultrasound, because it has a very small footprint, and so it allows you to obtain, based upon the way that it sends out the sound waves, to obtain a really wide field of view from a very narrow or small footprint. And secondly, we're going to place that probe in certain positions between the ribs, and we're also going to work on how we position the patient to optimize the image. Here's a view of the cardiac probe. This is also called a phased array probe because of how it sends out the ultrasound waves. And you'll see here just a standard subxiphoid cardiac view. This view is optimized because there is some liver in between the probe and the heart, and so that gives us a great acoustic window to get the image from. When we position the patient, if they can tolerate it, if this is a stable patient who's fairly mobile, then the best way to optimize the patient is to have them lie on their left side. Most of us, if you're right-hand dominant, are going to scan from the patient's right side, as you see here in this image. If the patient is critically ill or not that mobile, obviously you may have to just do this exam with them lying supine, and that's okay. But this is a way to optimize it, particularly if you're having trouble getting a perfect image. Here's a view of the axes of the heart that we're going to obtain. Recall that anytime we're examining a solid organ, we want to view it in both a longitudinal and a short axis. And the heart is no different. We're going to examine it in a long axis and a short axis in multiple planes. And one other thing to recall that's a little bit different about the cardiac ultrasound is once you obtain the optimal view, you really want to hold the ultrasound probe still while you're assessing it. This isn't a structure that we're going to fan the ultrasound probe through like we would a kidney or another solid organ. We want to hold the probe still because we're going to be assessing cardiac motion and the motion of different structures as a part of this scan. And so if you introduce probe movement into that, it can really throw off your interpretation. So you want to remember to hold the probe still. And here are the planes of the heart. The first plane that you're going to notice is the longitudinal axis, and that is seen here represented by the blue plane. And that is going to be what we're going to call parasternal long when we place the probe on the chest in a manner that slices through the heart in this plane. And then 90 degrees perpendicular to this is the short axis or transverse view of the heart. We're going to obtain this with a parasternal short approach. The third if you look at the green slice, is apical 4-chamber view, and that's going to be obtained with the probe out by the apex of the heart. And then the fourth view, which is in a similar plane but from a different probe position, is the subxiphoid view. Now, when we orient the screen for cardiac ultrasound, it can get a bit confusing. And this is because that by convention, cardiologists have always obtained their images with the indicator on the screen on the right side of the screen or right side of the image. Whereas if you'll recall up to this point, the indicator on the screen has always been on the left side of the screen or the left side of the image. So this is opposite what we've learned here to this point. This can get a bit confusing because most machines come from the manufacturer with this as the default setting. So most of us within ultrasound leave it this way. You will occasionally come across a machine where it's been manually switched to show up on the left side, and so that can introduce even further confusion. And there are some ultrasound directors and ultrasound leaders who have trained that way, so they'll set their machines up in that manner. So the way I mitigate this is to really teach how the heart should look on the screen for each view so that you can interpret if the image was acquired correctly, and then you can orient your probe whichever way is required to obtain that correct image. So basically, I'll kind of teach you the theory behind this, and I'll teach both approaches, but really it's best to really learn the underlying rationale behind it and how the image should look on the screen, so that no matter whether or not you pick up a machine with the indicator on the right or the left side, you can make sense of the image that you acquire. All right, hopefully that wasn't too confusing. So let's move on now to the actual views that we're going to obtain and where we're going to place the probe on the patient's chest. So the first view that we're going to talk about is the subxiphoid view. And to obtain the subxiphoid view, you'll place it just beneath the sternum as you would for the FAST exam, except that in cardiac mode, because the indicator on the screen is 180 degrees the opposite of what it was for the FAST, we're going to turn the probe 180 degrees so that the indicator is now towards the patient's left side. This is going to generate the exact same image on the screen as it would for a FAST exam, because not only has the indicator been flipped on the screen, but the probe has been flipped as well, so the image is actually going to be oriented the exact same on the screen. For the parasternal long view, we're going to put the probe around the third or fourth intercostal space on the patient's left chest, with the indicator pointed to the right shoulder so that the probe is in the longitudinal plane of the heart. For the parasternal short axis view, that probe gets turned 90 degrees so that the indicator is now towards the patient's left shoulder, and we're in a short axis view of the heart. The probe is otherwise around the same intercostal space. And lastly, for the apical 4-chamber view, the probe is going to be out by the PMI, or the apex of the heart, with the indicator also towards the left shoulder. So this is going to be just beneath the left nipple, kind of in the inframammary line. It really depends on the patient's heart itself and how large it is. But the best way to find this is either to start with the inframammary fold a couple centimeters below the left nipple, or you can start back from the parasternal short axis view, and then you can just slide the probe out towards the apex and then tilt the probe back up towards the base of the heart. Here's a standard B-mode view of the heart in the subxiphoid view, as well as the associated anatomical view. And here it is as a video. You can note here that the indicator on the screen is on the right side of the image, and so the indicator was on the patient's left. Let's go over the main structures we're seeing on the screen so we can make sure we're all on the same page. You see the liver in the near field. The right ventricle is then the chamber nearest the probe, the most inferior chamber on the patient. Adjacent to it is the right atrium. The largest chamber is the left ventricle, and then the chamber adjacent to that is the left atrium. Here again is a fairly normal view of a heart in the subxiphoid view. Looking at those three things that we talked about earlier that we want to assess for. First, we look at the sac or pericardium. Note here that in the upper left-hand corner of the image, just above the diaphragm, adjacent to the right ventricle, there is a tiny triangle of fluid that is probably just physiologic, but that is a bit of fluid in the pericardium. Next, we want to look at the squeeze. The left ventricle looks like it's squeezing great. We'll talk more about that in a minute. And then strain, the right ventricle doesn't look enlarged, and again, we'll get into that more in depth in just a bit. The subxiphoid view is going to be commonly used in the FAST exam. It's an easy to locate view unless the patient has a distended or very tender abdomen. It's great for evaluating the pericardium because you see the inferior aspect of the pericardium, and you get a good look at the left ventricle to assess its squeeze. It's not always the best at assessing for RV strain because depending upon your angle, you may or may not get a good view of the right ventricle, but it can be useful for that indication. Some tips to obtaining the subxiphoid view: you really want to keep the probe flat, which often means your hand has to be above the probe. It needs to be pushed down with a fair amount of pressure, which can sometimes make this a bit uncomfortable. And then the most important thing to remember is that you want the liver between the probe and the heart to get the best acoustic window. So to do this, sometimes you actually have to move the probe to the patient's right a bit so that you get the tip of the liver, and then you kind of want to look back towards the patient's heart or their left shoulder. This is going to be the best way to make sure that you have some liver between the probe and the heart. Let's take a look at some pathology on the subxiphoid view. Look at this heart and ask yourself those three questions. What do I think about the sac or pericardium? What do I think about the squeeze? And what do I think about any potential RV strain? Now, keep in mind there's a lot of other things that you might look for on echocardiography. A lot of people want to talk about how big the chambers are or how thick the chambers are, or is there any obvious problems with the valve, or is there subaortic stenosis? Different things like that. And what I would say about that is if you get to the point where you are comfortable with some of those advanced topics and techniques, then perhaps you could comment on them. But in general, I encourage the average emergency physician to really stick to evaluating the sac, squeeze, and strain unless they have fairly comprehensive further training in some of those advanced topics. So if you look at this video, let me make sure it's playing again. Let's go back to it. If you look at this video here, you'll note a few things. One, the heart looks rather hypokinetic. Its squeeze is not that good. And this will stand out to you the more hearts that you see. In particular, the left ventricle is hypokinetic, but by and large, the whole heart is hypokinetic. So I would call this global hypokinesis. You'll also see a bit of fluid in the inferior pericardium, so the top left of the image. Particularly during systole, you'll see some of it sneak in there. But the important thing to note is that the fluid is a very small volume, and the right atria and right ventricle do not seem to be under duress, or they don't seem to be compressed during diastole, so there's no signs of tamponade. Principally, this is just a very hypokinetic heart. Here's another subxiphoid view. What I like about this view is this is a very real-world image. This isn't a perfect textbook image. There's a little bit of artifact. You can't see the LV or RV perfectly, but this is a real-world image. This is often the view you might be able to get. So you can really make a couple of calls on this. One, you can see that there's a small stripe of pericardial fluid in the inferior pericardium. The right ventricle and right atria don't seem to be compressed or collapsing during diastole, so we don't suspect there's tamponade. And then the left ventricle seems a bit hypokinetic. To really make a firm call on that, I'd want more views because there's some degree of artifact, and it may be that the squeeze of the left ventricle is appropriate and just overwhelmed by some of the artifact. So I'd want more views on this, but you get a good amount of information even from a view such as this. Here's a view of a very, very large pericardial effusion. This is, I believe this was a dialysis patient, and they obviously very commonly have large pericardial effusions that are chronic that allow them to grow to this size. But what you'll see is a couple things. The free wall of the right ventricle appears to be a bit compressed. What we're really looking for specifically is diastolic collapse or compression of the free wall of the right ventricle or right atria. You do get a good view of the free wall of the right atria in this view, and it appears to be contracting during systole, expanding during diastole, and we don't see any specific diastolic collapse of the right atria, but the free wall of the right ventricle does appear a bit compressed, and so this would be concerning for tamponade or early tamponade. Let's look now at the parasternal long view. This is a great view of the heart. This is often my go-to view of the heart in a trauma patient if I can't get a subxiphoid view, because you just get a ton of information, and this is generally a fairly easy view to obtain. Recall that the indicator is going to be towards the patient's right shoulder. The probe is going to be around the third or fourth intercostal space, just leftward of the sternum, and you're going to orient it in the long axis view of the heart. You'll see here a B-mode image as well as the anatomic view of the heart and what you're looking for. We really want to center this view over the anterior leaflet of the mitral valve. We don't necessarily want to see the apex of the left ventricle in this view. We want to get a look at the mitral valve, the squeeze of the left ventricle, a bit of the left ventricular outflow tract and aorta, and then we also want to see a bit of the right ventricle in the near field. Here's an example of a fairly normal parasternal long view. Let's go over the anatomy again, just to make sure we're all on the same page. The largest chamber that you see contracting is, of course, the left ventricle. Next, you'll see the right ventricle in the near field. And more specifically, this tends to be just a thin slice of the right ventricle. Specifically, it tends to be the right ventricular outflow tract, which is just inside the pulmonic valve. For this reason, this tends to not be the best view for assessing for right ventricular strain. Next, you'll see the left atria, a bit in the far field, with the blood flowing through the mitral valve into the left ventricle. And next, identify the aortic valve, where you see the blood flowing from the left ventricular outflow tract through the aortic valve and then out the ascending aorta. The other landmark that on this view you really want to identify is actually a bit deep to the heart, and that is a transverse slice through the descending thoracic aorta. And this is a really useful landmark to identify because when we start to talk about pericardial effusions, it is possible for a left-sided pleural effusion to actually mimic a pericardial effusion because you'll see fluid around the left side of the heart. And so a large pleural effusion can be misinterpreted as a pericardial effusion. One way to avoid making that mistake is by asking yourself if the fluid that you're seeing goes over the aorta or stays just to the left of it. The reason that's important is because pericardial fluid is in the pericardium, and so will traverse over the aorta and across the mediastinum, whereas a left pleural effusion will stay in the left chest and won't cross over the mediastinum or over the aorta. The parasternal long is great for assessing contractility of the left ventricle, and it's also good for assessing the pericardium for any pericardial fluid or blood. But as discussed previously, it's not the best view for assessing for right ventricular strain or RV function. When you're talking about assessment of the left ventricle, one of the things you want to do is assess how the mitral valve is opening. And if the anterior leaflet of the mitral valve is opening briskly so that it's almost touching or touching the septum, then that probably represents pretty good function of the left side of the heart. When you're assessing the parasternal long view, you really want to make sure that your ultrasound view is right in the middle of the chamber of the LV and not off to one side or the other where you could pick up some of the wall. And I'll show you an example of that upcoming. Here's a few examples of pathology as seen in the parasternal long view. On this view, the first thing that should stand out is a large stripe of fluid all the way around your heart. And if you look closely, you can even identify the descending thoracic aorta in short axis just deep to the heart. So again, to make sure that this is a pericardial effusion and not a left-sided pleural effusion, you can see that the small stripe of fluid actually goes over the aorta and behind the left atria. So this is definitely a moderate to large pericardial effusion. In order to determine whether or not there was tamponade, I would want another view, like an apical view or a subxiphoid view, where I can see the right atria and the free wall of the right ventricle together. What looks wrong to you about this parasternal long view? Well, the most obvious thing that should stand out to you is that the entire heart, and specifically the left ventricle, are not beating well at all. This patient has an end-stage dilated cardiomyopathy. They have a big sick heart, and their left ventricle has a systolic ejection fraction of probably 5 to 10%. As you can see, the septum and the wall of the left ventricle do not come together much. In a normal adult, that distance which the septum and the lateral wall come together, it should be around 25 to 30%. That's a term called fractional shortening. But just remember, around 25 to 30% is the distance that those two walls of the left ventricle should collapse towards each other during systole. And you can see they're clearly not doing that here. In addition, the anterior leaflet of the mitral valve is not opening much at all, and it doesn't get anywhere near the septum. We don't see any pericardial fluid here, and again, this is not the best view for assessing for RV strain. Look closely at this view of the heart in the parasternal long axis and ask yourself what looks different. Let's go back to sac, squeeze, and strain. We don't see anything in the pericardium. We're not going to worry about right heart strain in this view. So what do you think about the squeeze of the left ventricle? Well, what I see is that in systole, it looks like the walls are almost touching. So is this a hyperdynamic heart where the ejection fraction is approaching 100%? In reality, the answer is no. What's happening here is that the image has been acquired oblique or out of plane to the lumen of the left ventricle, so that during systole, you're actually seeing the lateral wall of the left ventricle come into view as it contracts together. So this is actually a normally functioning left ventricle, but it appears that the walls are actually touching because the image was acquired just a bit out of plane. Here's another example of a parasternal long view with a severely hypokinetic left ventricle. I would call this moderate to severe hypokinesis. And here's an example of the heart in cardiac standstill. Now, occasionally you'll still see this agonal movement of the mitral valve, but this is, I would feel comfortable calling this cardiac standstill. There's no reasonably functional organized cardiac activity. Let's talk next about the parasternal short view. This view is obtained 90 degrees perpendicular to the parasternal long view with the image indicator towards the patient's left shoulder. This can be a bit challenging of a view to obtain because you're perpendicular to the ribs as well, and so there tends to be a bit more artifact than in the parasternal long view. But the ideal parasternal short view is obtained so that you see the left ventricle circumferentially, and then the right ventricle kind of as a crescent around the left ventricle in the upper left-hand portion of the image. We can obtain this view at many levels. You could move the probe really high up on the heart and see the atria and the aortic valve and other structures, or you could move it all the way down towards the apex. But those views are going to be suboptimal. The optimal view, because we're principally going to be looking at left ventricular function, is to place the probe at the level of the papillary muscles as seen here. Here's a view of the heart in the parasternal short axis. Let's review the anatomy. In the near field is the right ventricle, shaped like a crescent. Then you see the lumen of the left ventricle. You see the two papillary muscles. And in this view, you also see just a tad of the mitral valve, but we really want to be right at the level of the papillary muscles. So this is pretty much an ideal view. The next view I'm going to show you is a view wherein the sonographer moved the probe during the scan. And this is something you generally would not want to do once you've acquired an adequate image because, again, it makes interpretation more challenging. But the reason I include this view is because it allows you to see the different structures of the heart. If you were to start at the base of the heart or higher up and sweep down into the left ventricle. So at the beginning of this view, you actually see the aortic valve right in the center, and it kind of looks like a Mercedes-Benz sign because it has three lines that are kind of shaped like that symbol, and you can see it opening and closing right in the center. Deep to the aortic valve when you're seeing it in that view is the left atria. So then as you sweep down towards the apex of the heart, you're going to transition from the left atria to the mitral valve, and then eventually all the way into the lumen of the left ventricle. This view never gets all the way down as far as we would like it. It actually stops at the level of the mitral valve, which kind of looks like a fish mouth opening and closing. The reason that that is also a less than ideal view is not only because we want to assess the left ventricular function inside the lumen of it, but because were you to have right heart strain, the mitral annulus, which is kind of the skeleton of the heart that surrounds the mitral valve, can prevent collapse of the left ventricular septum at that level, and you could miss it. The parasternal short is a great view to assess the LV function because you see it completely circumferentially, so you're able to see a portion of all of the walls. You can assess for the squeeze and determine whether or not it looks normal or mildly, moderately, or severely hypokinetic. You can also assess the size of the right heart as it compares to the left heart. The normal right ventricle is 0.6 or maybe 2/3 the diameter of the left ventricle, and we will tolerate up to a 1-to-1 ratio before we call it concerning for right heart strain. Then, if the right heart strain is severe, you may see compression of the septum of the left ventricle, which in the short axis view we term the D side, because you take the left ventricle, which looks like an O, you compress the septum to where it's flat, and it starts to look like a capital letter D. Here's an example of the heart in short axis view. And again, I like this view because this is not an optimal view. This is a kind of a real world view. This is something you might actually acquire on a patient. It's also done with a bit older machine. But this is enough information to see that this left ventricle is not squeezing 100% normally. It's pretty good, but it's mildly hypokinetic. This is also a fairly suboptimal view. You see a lot of artifact, and it can actually be challenging to make out the left ventricle and the right ventricle. So this is not a textbook view, but I leave this in the presentation so that you can see that even a slightly suboptimal view or a challenging view can be interpreted. If you look closely here, you're able to make out the left ventricle, you're able to make out the right ventricle in the upper left-hand portion, and you're also able to see the papillary muscles inside the lumen of the LV. And once you find those structures, you can tell that the left ventricle is not squeezing very well at all. This patient has severe hypokinesis. Next, I want to show you an example of something that we don't talk a lot about because it's a bit of an advanced topic, but just to kind of explain to you how some of this works. This patient presented with an anterior MI, as seen on the EKG here. And before they went to the cath lab for their PCI, we threw the ultrasound probe on their chest. And a short axis view of the left ventricle allows you to see the septum, the anterior wall, and the lateral wall all at once. And if you look at the anterior wall, you can see that it's not contracting well at all compared to the other walls. So this is a regional wall motion abnormality that confirmed the diagnosis of a STEMI. Lastly, let's look at this short axis view of a young, unfortunate female patient who had a history of metastatic breast cancer and came in with chest pain, shortness of breath, and markedly abnormal vital signs. Identify the right ventricle in the upper left-hand portion of the image and the left ventricle towards the center of the screen. What's the first thing that should stand out to you? The left ventricle seems to be squeezing fine, and in fact it's tachycardic, but the right ventricle is enormous, well over a 1-to-1 ratio of the size of the left ventricle. And then if you look at the septum, the interventricular septum seems to be compressed, so that round, nice round left ventricle now looks like a capital D. And this was acute right heart strain from a submassive pulmonary embolus. The fourth and final cardiac view we're going to discuss is the apical 4-chamber view. This is a great view because it allows you to see all 4 chambers of the heart on the screen at one time, but it also can be one of the more challenging to obtain. We're going to obtain this view by placing the probe at the apex of the heart, which often is in the inframammary fold just a few centimeters beneath the left nipple, with the indicator towards the left shoulder when the machine is in standard cardiac view. The ideal view centers on the interventricular septum with it perpendicular to the probe, so that the right ventricle is on screen left, the left ventricle is on screen right, with the adjacent atria just deep to the ventricles, as seen here in this image. Here's an example of an ideal 4-chamber view. You see the interventricular septum is perpendicularly oriented right in the center of the screen, and you're able to see all 4 chambers at once. Let's identify them. The largest chamber, the left ventricle, is in the near field and on screen right. Deep to it is its adjacent atria, the left atria. The smaller of the 2 ventricles, the right ventricle, is on screen left, and its associated atria, the right atria, is just deep to it. Make sure you can identify all 4 chambers on each view. So what will we be assessing with the apical 4-chamber view? Well, pretty much everything that we really want to know. It's great for contractility and allows you to see the contractility of all 4 chambers and compare chamber size. It's great for assessing for RV dilatation or acute RV strain because you're able to compare them side by side. Remember that the right ventricle is roughly 2/3 the size of the left ventricle, and we're going to allow it to be up to a 1-to-1 ratio before we call it concerning for acute right heart strain. And more specifically, if you see the interventricular septum bowing towards the left ventricle, then that's going to be even more concerning for acute right heart strain. Lastly, you're obviously going to see pericardial effusions very well with this view, and should there be signs of tamponade, you generally will see them in this view since you're able to see the free wall of the right ventricle and the right atria. Here's an example of an apical 4-chamber view, and I really love this view because often learners miss the extremely large pericardial effusion. And if you look really closely, there is an approximately 4-centimeter effusion surrounding this heart, and you can actually see the parietal pericardium out to the side in the lower right-hand aspect of the screen. And the heart itself, though, doesn't seem to be any under duress. There's no signs of tamponade. The free wall of the right ventricle and right atria seem to be contracting well with systole, opening up and relaxing in diastole without any diastolic collapse. The left ventricle seems to be squeezing well. It doesn't look hypokinetic, and the right ventricle does not appear enlarged or under acute strain. In this example, we see that all 4 chambers appear hypokinetic, and specifically all 4 chambers appear dilated. And this is a dilated cardiomyopathy with global severe hypokinesis. We don't see any pericardial fluid, and the right ventricle doesn't look under acute strain. This is a view where the heart itself is very mobile in the pericardium because there is a very large pericardial effusion and the free wall of the right ventricle looks under duress. So this is concerning for tamponade. Look closely at this image and make sure you can identify all 4 chambers. Know that this image was obtained correctly. Now, one thing to bear in mind that I often get asked by learners is, why does it matter that I orient the probe correctly on the patient? Is it really that big a deal if the probe is flipped and the image is obtained in reverse? And my answer to you is exemplified here in this image. This image was obtained correctly. And if you look at the 2 ventricles, the larger ventricle appears to be on the left of the screen. And we know that this was obtained correctly, so we know that that is the right ventricle, and it is extremely enlarged compared to the left ventricle that is on the right side of the screen. The interventricular septum is also deviated into the left ventricle, and so this is acute right heart strain. This is an acutely dilated right ventricle. You can see that the septum is deviated. You can see that the heart is tachycardic. Now, what would happen if this image had been obtained in reverse? Perhaps you might miss that finding because you might miss that which ventricle was which. And alternatively, if this image was reversed and they did not have acute right heart strain, but you thought that the left ventricle was in fact the right ventricle, then you might overcall acute right heart strain. And so obtaining the apical view correctly is very important to make sure you're able to figure out which ventricle is which so that you can correctly assess their size. There's really no other significant findings in this view. The left ventricle seems to be contracting well. There is a trace pericardial effusion right at the apex. Here's our final apical 4-chamber view. I want you to look closely at this. This has some pathology on it that we haven't talked about before and is not part of the normal sac squeeze strain evaluation. If you look closely in the near field, you'll see the right and left ventricles. And if you look in the far field, you'll see that the two atria, the right and left atria, look markedly dilated compared to the ventricles. And what do we see in the left atria? Well, we see this hyperechoic kind of triangular shaped echogenic lesion, and that's actually an intraatrial thrombus. So this patient had a dilated atria, and because of that, they had an intraatrial thrombus. So this is a great example. It's not something we typically look for, but I thought I'd include it just so you can see that, there's plenty of other pathology you can see sometimes. So let's review the 4 views that we're going to obtain. We're going to obtain the subxiphoid view, the parasternal long view, the parasternal short view, and the apical 4-chamber view. On this diagram, the arrow of the blue indicator points towards the side of the patient or the shoulder that the indicator on the probe would point towards. Here's an example of a normal subxiphoid view with the apex of the heart pointed towards screen right. Here's a parasternal long view with the apex of the heart on screen left. Here's a parasternal short view. The left ventricle is round, it's centered, and the right ventricle is crescent shaped and to the top left of it on the image. And here's an apical 4-chamber view. The interventricular septum is perpendicularly oriented in the center of the screen. The 2 ventricles are in the near field, with the right ventricle on screen left, the left ventricle on screen right, and the adjacent atria just deep to them. This is how each image should look if it's obtained correctly. Recall that we're going to assess the sac, the squeeze, and the strain. We're going to assess the pericardium for any fluid or tamponade. You're going to look thoroughly in all areas. And if there is a significant fluid collection or effusion or blood, you're going to ask yourselves if there's signs of tamponade. Signs of tamponade include diastolic collapse of the free wall of the right ventricle or the right atria. Ask yourself about the squeeze of the heart. Are there any issues with the contractility? Is it hypokinetic or is it hyperdynamic? Look at the left ventricle in all views before making this call. And lastly, assess for acute right heart strain, which is best seen in the parasternal short view or the apical 4-chamber view. Here's an example of a parasternal long axis view that shows a moderate to severely hypokinetic left ventricle. There's no pericardial fluid, and this is not the best view to assess the right heart. Here's an example of a severely hypokinetic left ventricle with a small pericardial effusion. This may actually be a pleural effusion as well, since you don't see it clearly going over the descending thoracic aorta, but because I see a little bit of fluid in the near field over the anterior aspect of the heart, and because on a couple frames it does seem to actually go over that thoracic aorta, I do anticipate that this was a pericardial effusion. But just be aware, those left-sided pleural effusions can sometimes be hard to tell from a small pericardial effusion, so always look closely. I want to show you all a few more examples of tamponade. Here's tamponade in a subxiphoid view. You know that because you see liver in the near field, you see a large fluid collection in the pericardium, you see collapse of the free wall of the right ventricle, and diastolic collapse of the right atrial free wall. Here's a similar example in the apical view, and here's another example in a parasternal long view. A few more examples of pathology. This is a subxiphoid view with a severely hypokinetic heart and a small pericardial effusion in the upper left-hand portion of the image. This is a severe dilated cardiomyopathy with a global hypokinesis. The entire heart is hypokinetic. Notice how the anterior leaflet of the mitral valve is not opening briskly, nor is it coming anywhere close to the interventricular septum. You can also appreciate that the aortic valve is not opening briskly, and every part of this heart is just very, very weak. Here's the same patient in the apical 4-chamber view, a dilated cardiomyopathy with global hypokinesis. And here's an example of cardiac standstill in parasternal long. Lastly, let's look at a couple examples of acute right heart strain. Here's the D sign, a dilated right ventricle with a compressed interventricular septum, making the left ventricle look like a capital D. Here's acute right heart strain in the apical 4-chamber view. The right ventricle is well over a 1-to-1 ratio, the diameter of the left ventricle. And you can see the interventricular septum is deviated slightly inward to the left ventricle. All right, I want to transition now to discussing for a bit the measurement of the inferior vena cava. And this has gotten a lot of attention over the last number of years because we're always looking for an indirect marker of volume status, something that will help us manage fluid in the patient, something that will help us manage pressors. And so the IVC has gotten a lot of attention over the years as a potential non-invasive marker of fluid status. And this has been looked at in medical patients and in trauma patients. And at the end of the day, what we need to know about the IVC is that in reality, it is not the best marker of fluid status. What I want you to think about the IVC as a marker of is central venous pressure. And what we're going to do to measure that is measure the diameter of the IVC and also estimate the respiratory variation of how much that diameter changes when the patient takes a breath. There's a few important things to remember about this that people often overlook. One, the patient needs to be supine. They need to be in a very neutral position. And two, you don't want the patient to take an augmented or more deep or powerful inspiration than they would usually. All the studies in this assume a patient is breathing normally and spontaneously. And so if you have the patient take an augmented inspiration or breathe deeply or more deeply than usual, then you're not going to get an accurate measurement. How are we going to measure this? Well, we're going to have the patient lying supine, as noted. We're going to place the transducer at the subxiphoid position in a sagittal plane just to the right of midline. The marker on the probe is going to go towards the patient's head since this is an abdominal view. And we're going to obtain a long axis view of the IVC as it enters the right atria. This is called the atriocaval junction. And it's what's going to help us identify that what we are seeing is in fact the IVC and not another structure such as the abdominal aorta. There's your right atria, there's your IVC, and we're going to measure the IVC diameter about 2 to 3 centimeters inferior to that atriocaval junction or right beneath the level of the hepatic vein, which is that anechoic vein or vessel that you see right above the red arrow draining into the IVC. That's where we're going to measure. We're not going to measure below that because as you can see in this image, the IVC gets much smaller. Here's an example of a fairly normal IVC. If you want to measure it other than to just eyeball it, you can put M mode onto the area of interest. That will allow you to see the specific diameter during expiration and inhalation. And then the machine will display those distances for you, which you could calculate the percent of respiratory variation. Now in reality, most of us just use the hash marks on the side of the screen to eyeball the diameter and estimate the respiratory variation. But sometimes you may want to know the specific number, particularly if you're assessing for change after a fluid bolus or perhaps if you're doing research. This is a chart that shows IVC size or diameter and respiratory variability and the estimated right atrial pressure. This is a chart that's been in the literature for years and is a great starter when you're learning this measurement of the IVC, but it's not extremely accurate, and there are patients who will have IVC diameters and respiratory variabilities that don't fit specifically into this chart. And so what I teach our residents is to really think of the IVC as falling into one of three categories. You'll either have an IVC that has somewhere in the neighborhood of 25 to 75% respiratory variability. That means the diameter decreases 25 to 75% when the patient takes a breath. Or you'll have patients that have less than 25% respiratory variability, meaning their IVC is distended and has less respiratory variability than normal. Or you'll have patients that have more than 75% respiratory variability, meaning their IVC collapses more than 75% when they take a breath. The patients who have less respiratory variability and have a distended IVC have a higher than normal central venous pressure. Patients who have an IVC with respiratory variability in the 25 to 75% range probably have a roughly normal central venous pressure. And those patients that have respiratory variability of more than 75% probably have a low central venous pressure. So that is a way that I categorize my patients with their IVC findings into one of three categories. And I kind of think of the IVC as somewhat of, when you put your finger in the wind and you're just trying to figure out roughly which way the wind is blowing, but you're not being all that precise. That's somewhat of what the IVC is doing, and I don't find it to be near as specific as this chart suggests. What do we do with that data? Well, if your normal central venous pressure is 5 to 10 millimeters of mercury, and the normal IVC is roughly 1.5 to 2.5 centimeters with 50% respiratory variation, or as we mentioned before, 25 to 75% respiratory variation, then we can use that data somewhat to help guide our management of hypotension when we want to decide if the patient needs more fluids or if they might need to be started on pressors. This is not a decision that I feel should be based on the IVC alone. I think it needs to be taken in the context of what the patient's heart is doing when you do their cardiac ultrasound. How is their contractility? Is there anything else that could be contributory? And only after you have all of that information should you make a decision. And of course, you're always taking the patient's clinical context into consideration. Here's a great example of an IVC ultrasound. You can see the IVC and the right atria at the same time, that atriocaval junction that confirms that this is in fact the IVC. Recall that we're going to measure 2 to 3 centimeters below the diaphragm, just below that hepatic vein that you see draining into the IVC. And this patient's IVC is around 1.5 centimeters in diameter using the hash marks on the side of the screen, and probably collapses about 75% or so during inspiration. So this is certainly a patient that you could consider more fluids in if they were septic and you had already given them their initial fluid bolus. Recall that if a patient is intubated, this physiology is going to change, and so you cannot reliably use the IVC as well in intubated patients. There is some data from authors who have attempted to study that, but for now I would recommend not considering this to be a reliable indicator or as reliable in patients who are intubated because they're now on positive pressure ventilation. So I would recommend personally just doing this in the non-intubated patient, recalling again that we don't ask the patient to take an augmented deep breath. You just let them breathe normally as they would. Here's another example of an IVC ultrasound. I like this one because it's not a textbook image. This is a real life image that you might obtain. It's not perfect. There's some artifact, there's some movement of the probe, some movement of the patient, and yet we're still able to get pretty good data off of this. You can see the IVC is small. You can confirm it's the IVC by seeing it drain into the right atria, and you can see that hepatic vein draining into it. The diameter of this IVC is very small. It's less than 1 centimeter, and when the patient does take a breath, you can see that it collapses 100%. So this is a patient that would definitely need more fluids. Here's an example of a plethoric IVC. Identify the atriocaval junction, identify the IVC, and note how it's very large. It's around 2 centimeters, if not a bit more, and during inspiration it has almost no respiratory variability. So this is a patient who likely has a high central venous pressure and probably would not benefit from more fluids if that was the clinical decision being considered. Here's another example of a distended IVC that I really like, not only because there is secondary pathology contained in this video, but because I kind of think it looks like an angry goblin. So ask yourself, what is the size of this IVC? Well, it's about 2 to 2.5 centimeters in diameter, and it has minimal respiratory variation. So this likely represents a high central venous pressure, and were this patient septic or persistently hypotensive after fluid administration, you'd either have to start them on pressors or consider another cause. And if you look closely in this video, is there another potential cause for hypotension that you can see? Look up above the diaphragm where you see the heart moving. Do you see anything on this somewhat limited view of the heart that could be contributory to hypotension? Well, the heart is tachycardic, and there's a fluid stripe around it in the pericardium. So could this patient have a large pericardial effusion or tamponade? They would definitely need a cardiac ultrasound to find out. Well, there you have it. That is the cardiac ultrasound for the emergency department and IVC assessment. And there is a lot of information there, and it may be new for a lot of you. So if you have any questions, or if you don't think you really nailed down any of those concepts, make sure you go back through and look at them again, because these are concepts that are very important to your patients in the emergency department as you're working them up and taking care of them. So thanks for your attention. Let me know if you have any questions, and have a great day.